Extract 1.
Mr. Smithers?
That's right, Toby Smithers.
Now, I think you've been having some stomach problems.
Yes, that's right, for some time actually.
Okay, I've got some notes here, but perhaps you can tell me in your own words about those problems. About any treatment you've been having, or anything else you can remember that seems relevant.
Okay. It all started about 9 months ago with a stomach upset.
Okay.
I thought I'd caught the vomiting bug that was going round.
Yes.
Basically, I just couldn't keep anything down.
Mm-hmm.
No diarrhea or anything, but it was pretty bad.
Right.
Anyway, it cleared up in a couple of days, and I went back to eating normally. The thing was, though, from that time on, whenever I had a meal, lunch or dinner, I'd feel incredibly sleepy almost before I'd finished, and for about half an hour afterwards.
Mm-hmm.
I didn't feel tired as such, I mean, not in the sense of fatigue. It's just that I could hardly keep my eyes open.
I see. Were you in any pain?
No, none at all. The only other symptom was that I was getting very thirsty, especially at night, so I was drinking a lot.
Right.
So I went to see the doctor, expecting some simple explanation, but she said my symptoms were quite unusual. Well, not the drinking. She explained that the stomach upset had left me dehydrated.
Yes, that's right.
But it didn't explain my other main symptom.
And the dehydration passed?
Yeah, that was just a temporary thing.
Mm-hmm.
Then she asked me if I'd ever had stomach cancer, which was a bit worrying.
But you haven't?
No. But then she explained that there's a condition that has similar symptoms to those I had. She didn't think I actually had that condition because it generally affects people who've had stomach surgery, and I hadn't. It's called gastric dumping syndrome.
Oh, yes.
Anyway, what she suggested as, well, like an interim measure was following the treatment plan for that syndrome, even though I probably hadn't got it.
Mm-hmm.
So I had to keep drinking because I needed to keep my fluid levels up.
Yes.
But not whilst I was eating. So in other words, I had to separate the two activities by about half an hour. Then as for the meals themselves, she suggested an eating regime that she called little and often. So, no major blowouts and no skipping meals either.
Sure. Did that help?
Yeah, it did, but it was only meant to help me in the short term. Because meanwhile, I had various tests. I gave a urine sample, went for a blood test, neither of which showed up anything untoward. So I just hoped it'd clear up of its own accord.
But it didn't.
Well, no. The regime worked all right, but as soon as I went back to eating and drinking normally, the symptoms would come back.
Okay.
So the doctor referred me for an endoscopy. I saw a gastroenterologist for that. He'd looked at my other test results and examined me and everything.
Sure.
And of course, once the results of that came back, they showed that I'd got Helicobacter pylori.
I see.
So I went on the course of treatment, the 3 drugs for 2 weeks,
Yes.
2 different antibiotics and an antacid. That's the combination which gets rid of it.
Yes.
After that, I went back for a breath test, and that was all clear. So I thought that'd be the end of it, and I'd be back to normal.
But you're not.
Well, I've given it a couple of months, but the symptoms are the same.
Okay.
If I stick to the eating regime, I'm okay. When I come off it, I'm back to square one. So I'm thinking, sure, the stomach problem that the gastroenterologist found has been dealt with, but that wasn't what was causing the original problem.
And how's this affecting your everyday life?
I can live with it. Obviously, it would be different if I was driving for a living or operating machinery, but I'm a teacher, so it's okay. But to cut a long story short, I asked for a second opinion, and so here I am.
Extract 2. Questions 13 to 24. You hear a physician talking to a patient called Thomas Andrews. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Good morning, Doctor.
Good morning. Have seated. May I know your problem?
Well, I'm a patient with hypertension, chronic intermittent bipedal edema, and recurrent leg venous ulcers. I had a vascular surgery for non-healing right ankle stasis ulcer. I have a serious concern today that I had a low-grade fever of 100.2 early this morning. Otherwise everything was well. The thing is, I was not even aware of the fever. I do have some ankle pain, worse on the right than the left.
Okay, what's your age?
52, Doctor.
Do you drink or smoke?
No, Doctor.
Are you getting nausea, vomiting or diarrhea?
No, Doctor.
May I know your previous illness history?
Well, hypertension, exploratory laparotomy in 2016 for abdominal obstruction, cholecystectomy in 2017, chronic intermittent bipedal edema, venous insufficiency, chronic recurrent stasis ulcers.
What medications are you taking?
Primaxine, daptomycin, clonidine, furosemide, potassium chloride, lisinopril, metoprolol, ranitidine, Colace, amlodipine, zinc sulfate, Lortab, multivitamins with minerals.
Are you allergic to any medicine?
No, Doctor.
Well, the physical examination shows heart rate 73, respiratory rate 20, blood pressure 104/67, temperature 98.3, and oxygen saturation 92% on room air. There is hyperpigmentation involving distal calf on both legs. There is an open wound on the right medial malleolar area measuring 9 by 5 centimeters with minimal serous drainage. Periwound is hyperpigmentated with a hint of erythema extending proximally to the medial aspect, distal third of the right lower leg. There is warmth but minimal tenderness on palpation of this area. There is also a wound on the right lateral malleolar area measuring 4 by 3 centimeters. Another open wound on the left medial malleolar area measuring 7 by 4 centimeters. Wound edges are poorly defined. Laboratory results show white blood cell count is 5.8 with 64% neutrophils, H&H 11.3/33.8, and platelet count 176,000. BUN and creatine 9.2/0.52, albumin 3.6, AST 25, ALT 9, alk-phos 87, and total bilirubin 0.6. Chest X-ray shows chronic bibasilar subsegmental atelectasis. likely related to elevated hemidiaphragm, secondary to chronic ileus. No absolute findings. You have multiple previous wound cultures positive for Pseudomonas, Enterococcus, and Stenotrophomonas. Fevers, right leg, ankle cellulitis, chronic recurrent bilateral ankle venous ulcers, hypertension. I am ordering 2 sets of blood cultures, injection with daptomycin and primaxin 4. I am ordering an MRI of the right ankle to check for underlying osteomyelitis. Follow-up results of wound cultures. Additional treatment and medications are upon follow-up.
Part B. In this part of the test, there are 6 short extracts relating to the work of health professionals. For questions 25 to 30, choose answer A, B or C, which you think best fits according to what you hear. Question 25. You hear 2 nurses talking about a plan for a citywide drive. Now read the question.
In order to commemorate World AIDS Day, Marvin asked that we organise a citywide drive.
Wow, that sounds exciting. So, what exactly do we have to do? It's not actually a drive in a car, is it?
No, the 2 main goals are to test and educate. So I thought we could visit some local colleges, universities and businesses. We could host info sessions and a Q&A. Then we could follow it up with some voluntary tests and or impromptu counselling if need be.
I'll check my inventory for disposable test needles. How about you work on PowerPoint slides for the presentation?
I'll get right on that. It should be done within the next few days, hopefully, leaving me with enough time to work on what I'm actually going to say to the crowd during these World AIDS Day info sessions. Gosh, it's such a buzz connecting with our local community like this.
Question 26. You hear a conversation between a pharmacist and her co-worker. Now read the question.
Would you please help me sort these medications? Some of them have expired and now they're all mixed up.
Sure. Shall I start with A to H? And you can do I to Z.
Yes, that sounds like a plan. Thank you so much, Kate. And again, I'm sorry to have to pull you in over the weekend like this.
That's okay. I wouldn't have been doing much anyway, just helping out with my dogs. One of them had a nasty fall, and we've had to get her a new collar.
Oh, ouch. You haven't left her alone, have you?
No, my partner's looking after her whilst I'm here. I know it's urgent and that we're short-staffed. What with Luis not being here again and all.
It's the 3rd time this month, and I am really sick of it. No one else has been away as much, and it's driving me around the bend how much extra we have to do around here these days.
Question 27. You hear a team briefing where overall performance is being highlighted. Now read the question.
Thank you all for coming. I'll make this brief, shall I? My department has noticed an increase in the number of absences on the ward of late, and it is causing us some concern. This is a hospital, and when we're short-staffed, patient care suffers. With the HQC breathing down our necks, it's not something that we can continue to have happen. We are considering taking drastic measures in order to protect our patients and our reputations, and that may just include terminating frequent absentees.
Surely, that's a little harsh.
Well, it's a serious matter, and despite several disciplinaries, we've concluded that talking to them hasn't worked.
If I may offer a suggestion, I think that right now, I think it's a little too easy to take leave.
What do you mean?
Well, at the moment, we download a form off the internet and submit it to our line managers. Perhaps if it were a little more difficult, we'd have better luck.
Fine. I'll see if we can alter the current procedure slightly, and if that doesn't work, then we'll need to move to a plan B.
Question 28. You hear a conversation between two nurses. Now read the question.
Still here, are you, Linda?
Yes, I am. I'm on the graveyard shift tonight, Bobby. You're done now, aren't you?
Yeah, just finishing up some of my documentation from earlier, and then I'll call it a night. Just so you know, Bed 5's getting a little angsty about later. He's worried about how he won't be able to drift off again.
Can you blame him? He's really had a rough time this week. Wait, is he the hemophilic patient or the one with diabetes?
Mr. Wilson's diabetic. He'll need his insulin topping up, but that won't be until morning now. What time will you be doing the next round?
Midnight.
Okay, that's good. Please make sure you remember to disconnect Mr. Wilson's saline drip before then, otherwise he'll be fussing into the early hours. He's been assessed several times today, so he won't need any more of those, but everything else on his care plan needs to be attended to.
Got it. Thank you.
Question 29. You hear a morning briefing. Now read the question.
All right. Today we need to address some serious problems in this department. I don't know where to start, really. We've got so much that we need to remedy that it'll take weeks, if not months, to get us where we need to be. Ideally, we'll be able to increase the number of personnel devoted to the tasks we're working on, such as clearing up all the post-discharge paperwork that we've got piled up. However, I don't know if we'll be able to change people's job roles at such short notice. Never mind the fact that all of the larger rooms that will be able to accommodate large teams are all located on the other side of the ward. If anyone finds that they have a couple of hours spare this or next week, please make sure that you get in touch with either myself or Carla, okay?
Question 30. You hear a conversation between two nurses. Now read the question.
Are you coming to the school later? I've been asked to organise the vaccinations for the under-16s.
Oh, is that today?
Yes, why? Will that be a problem?
Not really. I'm just trying to organise my day. Can I ask you one thing, though?
Of course.
We've organised tetanus vaccinations at that school before, if I remember correctly. Now, if they've all been immunised against the flu, why are we having to give H1N1 vaccinations today?
I wanted the same thing, and you know what? It beats me. But that's what it says on the chart, so that's what we'll have to give them.
All right, no worries. Give me 10 minutes and I'll clear up the rest of my day and prep to go with you.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C which fits best, according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an interview with a scrub nurse called Joanna Swan. You now have 90 seconds to read questions 31 to 36.
Today, I'm talking to Joanna Swan, who works as a scrub nurse in the operating theatre. Joanna, firstly, remind us what a scrub nurse is exactly and where the name comes from.
Sure. Well, perioperative nurse is the correct term, of course, but basically we're all familiar with the notion of scrubbing in. You know, you've seen surgeons doing it. It's not just washing your hands, it's doing that very thorough cleaning to ensure you're completely sterile before you go anywhere near the patient or the surgical instruments. But the name scrub nurse doesn't quite capture the full role. I mean, basically, your job's to prepare the operating room for surgery. You lay out the instruments, hand them to the surgeon when asked, and you're also responsible for monitoring the patient. So you're like the bridge between the surgical team and everyone else who's supporting the patient.
So how did you first get into this type of nursing?
I remember one of my most formative experiences as a student nurse was shadowing a perioperative nurse in theatre. I had to scrub up too, and I was expected to lend a hand because they didn't want somebody just standing around in the way. It was all new to me, and I was worried how I'd react. I was fine around blood, but I'd never seen a wound being created before. It was a 30-minute hernia op, so nothing special, but it left a deep impression on me. Then later, when I'd reached the stage in my career where I was up for a challenge, that image came back to me.
And what sort of background do you need to go into this kind of nursing?
Well, you can do specialist courses, but I think what's crucial is having a fair amount of nursing experience, particularly in critical care settings. That was true of me, and there's really no substitute for that. To be honest, the job wouldn't suit everybody. The hours can be grueling, and the work's very demanding. You can't just pop out to the bathroom or have a snack when you feel like it. And you're stuck in a small room with some quite strong personalities who are also under pressure. So it's a very intense environment. but also a very rewarding one.
And what skills does it call for?
Well, basically every second counts. You've got to be very efficient and able to think ahead and get things organised. What needs doing immediately, what can wait a few moments, what you need to do now because you might not get the chance later, and so on. I mean, that's the kind of thing you can train somebody for up to a point. But to do it well, you've got to be in the mindset to start with. Attention to detail is crucial. If that's not how you are, then you're not going to be right for the job. You have to be there mentally 100% as well as physically.
And I guess the idea of the team is really important in theatre.
Indeed. It's got to be part of the system. I mean, especially when you're on call, you never know who you're going to be working with. For an operating theatre to run smoothly, there's got to be clear communication and coordination between everyone concerned, because it's the collaboration within the team that keeps patients alive. In my hospital, to promote team spirit, we set great store by meetings. The preoperative briefing, of course, but also meetings to discuss issues and generate new ideas. As a nurse, it's great to feel that your voice counts, and that's not always the case in medicine. So for me, that's a big plus. We also take opportunities to debrief staff after difficult events. I mean, that's crucial too.
And what about the interactions with the patients?
Well, some people have the idea that in the operating theatre you're going to be having just mechanistic interventions on patients who are in no position to respond or interact with the nurse, that you're just providing support to the surgeon and the anaesthetist. But these days, theatre nurses are required to have a holistic, patient-centred approach to care, and this extends beyond the period of the patient's actual surgical experience. Preoperative visitings become the norm, so that patients see a familiar face when they come in for treatment, and this can really reduce stress levels on the day for the patient. For me, this is a really positive development, and I'm always keen to take on that role.
Listening Part C. You hear a primary care physician called Dr. Greg Richter giving a presentation on the subject of secondary prevention of suicide. You now have 90 seconds to read questions 1 to 6.
Hi, my name is Dr. Greg Richter. I'm a primary care physician, researcher and author. My topic today is secondary prevention of suicide. Suicide poses major threats to public health worldwide. In 2002, suicide accounted for about 30,000 deaths in the US alone, and almost 900,000 deaths worldwide. This translates to 1.5% of all deaths related to disease. However, I am convinced that these figures can and should be reduced. According to recent research, suicidal behaviour can be distinguished into 4 distinct categories. Completed suicide, where a person has been successful in their attempt to commit suicide. Suicide attempt, where a person has been unsuccessful in their attempt to commit suicide. Suicidal ideation, which is where a person is having suicidal thoughts. Self-harm behaviour, where a person injures themselves deliberately. It is important to realise that 83% of people who commit suicide or attempt suicide have had contact with a doctor within a year of their death, and up to 66% of people who commit or attempt suicide have had such contact within a month of their death. We can divide suicide prevention into 3 categories, which are primary, secondary, or tertiary. Primary suicide prevention aims to reduce the number of new cases of suicide in the general population. Secondary suicide prevention aims to decrease the likelihood of a suicide attempt in high-risk patients. Tertiary suicide prevention occurs in response to completed suicides and attempts to diminish suicide in a particular geographical area or in a particular age group. The clinical evaluation of the medical and psychiatric history of a patient and of their current state is the crucial and essential element of the suicide assessment process. It is important because it enables the identification of risk factors in order to assess the patient's immediate safety and the best setting for treatment, and also to develop diagnoses and treatment strategies. Psychiatric illness is a major contributing factor to suicide risk, with mood disorders such as major depressive disorder and bipolar disorder being associated with about 60% of suicides. Indeed, psychiatric disorders are diagnosed in more than 90% of completed suicides, and more than 80% of these psychiatric disorders are untreated. Thus, the recognition and treatment of individuals with psychiatric disorders, specifically mood disorders, are essential components of secondary suicide prevention. In addition, the subjective rating of the severity of depression is one of the most powerful predictors of future suicidal acts. Therefore, assessing and managing depression, as well as being aware of the suicide risks in psychologically, medically, and neurologically disordered individuals, is an important aspect of secondary suicide prevention. Consequently, physicians need to be taught to recognise the association between subjective findings and suicide. Antidepressant medications are the most widely used pharmacological interventions in secondary suicide prevention, but studies of their effectiveness in reducing suicide attempts have had mixed results. Among adults younger than 25, the effect of antidepressants seems to be neutral on suicide behaviour, but it seems to reduce the risk of suicidal behaviour in the elderly. Thus, the relationship between antidepressants and suicide needs further studies before this class of drugs can be safely used for the secondary prevention of suicide. Better psychological and pharmacological treatment of depression and alcoholism also appears to decrease suicide rates. Many studies show that suicides by particular methods, for example, firearms, domestic gas, or pesticides, decrease after the introduction of legal restrictions that reduce access to such means. This reduction in suicide rates is particularly influential in regions where the specific means of restriction correlates with a common method of suicide. For example, in the UK, the reduction of carbon monoxide in domestic gas since 1958 and the reduced availability of analgesics since the mid-1990s have both decreased UK suicide rates. Many studies have also exposed a need for a decrease in reporting of suicide and for responsible reporting. Media blackouts in reporting suicide have coincided with a decrease in suicide rates, because reports of suicide in the media tend to glamorise suicide for vulnerable individuals. However, the internet is of increasing concern, with blogs and chat rooms providing accessible instructions for suicide. Despite our increasing knowledge of secondary suicide prevention, there are still many gaps in the research, and looking to the future, thorough evaluations and appropriate treatments of patients with depressive disorders and other psychiatric illnesses should help to improve the efficacy of secondary prevention of suicide. But it is also clear that more research into new approaches for the prevention and treatment of suicidal behaviour remains essential.